My name is Taylor Heald-Sargent, and I'm an attending physician at the Ann and Robert H. Lurie Children's Hospital in Chicago, Illinois. I'm an infectious diseases physician that specializes in patients who have had transplants. Before I start my talk today, which is going to be about taking out the trash, clearing chicken pox, I wanted to let you guys know that as a disclosure, Kamada is a maker of varicella antibody product that we'll be talking about today, and they're a sponsor of this conference, but I have not received any money or funding from them directly. However, I am a part of a research trial that is funded by a different varicella vaccine maker, GSK. I will not be discussing my research today or any off-label products. I'm also a member of the Transplant Families Medical Advisory Committee and happy to be able to speak with you guys today. The goal of my presentation for this is to just raise some awareness of the clinical impact of varicella virus, what it causes, because you might not have heard of varicella, but probably heard of chickenpox, and what you can do to protect yourself and your child or family members from the disease caused by varicella. I'm going to go through three main parts today. The first, I'm going to introduce some immunology concepts around specifically active and passive immunization. And I'm going to discuss a little bit about the varicella virus, the disease it causes, and how you might become exposed to the virus. Then finally, and somewhat maybe the most important part, I want to pose some steps that you can take if you've been exposed or you think you might have been made at risk for getting the virus. So to start out, I wanted to talk about the immune system. And on this slide here, we have a nasty, scary looking virus. Battling it out is with the T cell. And so the T cell is part of the immune system. And one of the analogies or metaphors I like to think about the immune system is thinking of them as kind of the trash collectors of the body. And they take out the trash, they get rid of it, they break it up, they label it and get it out of the body so that we can go on our normal activities. So to start and to make sure that we're all on the same page, I want to go over just a bit of immunology. I'll try not to scare you, to make sure that we all have the background. So really broad here, the immune system is what protects us from foreign invaders. And those foreign invaders can be bacteria, viruses, fungi, and there's lots of different parts of the immune system. I am going to try not to show any huge slides that are scary of all the different parts because you don't need to necessarily know them, but you might have heard of some of them. So when you get your blood work done at the doctor, they probably talk about your white blood cell count because that's what we think of as a big part of the immune system. When we say your white blood cell count, we actually usually further divide that up or get a differential. When you see a CBC with differential, that's what we're looking at. And the differential tells you how many different types of white blood cells we have. And in that list, you might see things like neutrophils or monocytes. There's also macrophages, NK cells, and then, of course, T and B cells, which we have here. And those are all different parts of the immune system that help protect you. There's also different parts of the immune system that aren't necessarily cells, but they're made by these cells or they help these cells out. And those are things like antibodies or chemokines, cytokines. Sometimes you hear about these like IL-1 or IL-6 or antibodies when we talk about if you're antibody positive, and that means that you might have these antibodies against specific things. So these antibodies that can help us target and react to specific pathogens are directed at the outside usually or at small pieces of these invaders. So in this presentation, it's going to be mainly viruses. And so you can think of them, if they're part of that trash collection team, they're the ones that maybe are making the labels and telling the dump truck that they need to pick this up and take it away, or that another cell needs to break it down. So in this case, this picture has them as B cells are the ones that make the antibodies. So they're the label makers. And these guys are helped out by those T cells. So they're shaking hands here because you have these helper T cells that you need to help the B cells make these antibodies. So just very basically, that's a nice introduction. To take a step towards the realm of vaccines, there's also a couple different types of vaccines or immunizations I want you to know about. So there's active vaccination. And this is where what you think of when we think of most types of vaccines. And active vaccination involves directly injecting some part or whole of the virus, bacteria, pathogen, whatever you have. And this can be done a couple of different ways. So on the left, you have an example of something, or what I'm trying to show is like a subunit or an activated vaccine, where you're not actually getting the virus or the bacteria directly injected into you. You're just getting pieces of it. They're broken down so that the immune system can recognize the piece. But then later, when they recognize it on the whole virus or bacteria, they'll respond the same way. Because this is not the entire pathogen, not the whole virus, it can't make you sick. It's not actually going to replicate in your body. It can make you not feel great, maybe even feel like you're sick, because that's your immune system responding to it. And so types of these vaccines are examples would be influenza or hepatitis. And I'm sure you've heard of people, maybe you yourself have said, I felt like I got the flu after I got the flu shot. And this is why. It's not because you actually had the virus replicating in you. It's because we tricked your immune system into thinking you had the virus. And then your immune system responded with those chemokines, cytokines, various things to make you feel sick. So you thought you were. It was really just being tricked and you weren't actually ill. But that way, next time you see it, you can respond even faster and clear it before you get the disease. Now, this is contrasted to a different type of active vaccination, which are the live attenuated vaccines. Some of you might be really familiar about hearing about these because a lot of times after transplant, providers recommend that you don't receive them because these are made from actual viruses that have been made weaker before they're injected into you. So we attenuate them in the laboratory, and then when they're injected into the body, they actually can replicate just a little bit. And that's because it wants to stimulate your immune system enough that the immune system gets some practice controlling it, but the virus doesn't get out of control. Of course, you need your immune system to still control these. And that's why sometimes after transplant, or if you're on some other immunological modifiers, they might say you shouldn't be getting these vaccines. That doesn't go for everyone, and you should talk to your doctor about it specifically. Now, these ones, because they replicate a little bit in your body, sometimes they make you feel sick a few days later. And some, like the measles virus vaccine or the chickenpox vaccine, you might even get a spot or two that would look like the rash you would get if you were sick, but it stays just right around where the vaccine was injected. It doesn't go other places because your immune system controls it. So those are two different types of what I'm calling active vaccination. Now, what do I mean by active vaccination or immunization? So this is, as I mentioned, when you take those subunits or the weakened viruses and you inject them directly. Your T cells and your B cells are going to get presented with the parts of these bacteria or viruses, and they're basically going to study them. And they're going to learn how to remember what they look like so that if they see them again, they will be able to react even faster because it takes a little bit of time, just like studying for a test. Each time you study, you learn a little better. So that helps you develop memory and some memory T cells and B cells to help fight. Then these T cells and B cells, once they've learned what they're fighting against, if they get presented with the pathogen later, they can do a couple different things. The T cells can actually directly fight sometimes the virus or bacteria or cells infected with them. And then, as I mentioned earlier, they help out the B cells to make those antibodies. So they can do various things to help clear out the pathogen if they come back. Examples of these are flu vaccine or the chickenpox vaccine that you would get when you're a younger child, so the varicella vaccine that infants get. Now, contrast to this is passive immunization. Passive immunization doesn't have anything to do with training those white blood cells, those T cells, those B cells. This is just injecting the antibodies directly into your body. So the idea is if you have these viruses or bacteria, in this case, this presentation's viruses, in your body and you inject the antibodies, then those can coat them and let the rest of the immune system know to clear them out, that something is not right about these. These are foreign pathogens. These antibodies, because they're not being continually made by that B cell label maker, they're shorter lived and they don't have any memory. So you're not going to be able to recall this years later. They're good for that just-in-time protection. Say you've been exposed and you want to get protection such as this, or some of you might have heard RSV. They have antibodies or passive immunizations. It used to be Synagis. Now there's newer ones out that last a little bit longer. These antibodies are given before you have the pathogen and they can last through the season, but not much longer because the antibodies go away and there's not memory. So that's passive immunization. So now we've covered the basics of the immune system. I won't lay any more on you. And active versus passive immunization. Now I want to talk a bit about varicella and how we can protect ourselves from it. So varicella zoster virus, also known as VZV, and I'll try to keep saying varicella virus, but it has so many names, sometimes I get tripped up. It is a highly contagious virus. So if you are in close contact or someone is in close contact with somebody that's infected and they have never had an active immunization, they don't have any protection, they haven't been infected before, about 90% of people will get this infection. It's very, very contagious. It causes two different types of infection, and those are called chickenpox, and that's what you get the first time you get infected, or shingles, or herpes zoster. It's varicella zoster virus. It's also a member of the herpes virus family. So that's why some people say herpes zoster. It gets so confusing. I apologize. I did not come up with the names. I can just help tell you them. So the chickenpox is what you get the first time you've been exposed or been infected with this virus. And it can go everywhere. And you probably remember maybe from when you were a child or seeing it in others that it's very itchy. I can still remember bathing in calamine or some oatmeal baths or something when I was young. And it's a rash that comes on mainly on your trunk, but can go other places. And it develops over time. And so you have continually new lesions turning over that could be in crops or waves. And for a healthy child with a functioning immune system, you can get 250 to 500 of these rash spots, these lesions, over 2 to 4 times. So it can last quite a while. So you can imagine somebody that does not have a great immune system, how this can last even longer. Now, one other thing I wanted to mention here is that the 90% transmission contagiousness rate is for people that have chickenpox. The zoster can also spread the virus, and that's because it does have the virus in it. It's just localized. So herpes zoster is just on one little area. Well, sometimes it can be a whole longer area, but depends on where it is hiding in your body, because this is like all other herpes viruses, a virus that hides out and you never get rid of the rest of your life. So if it comes out of hiding and causes a zoster rash or kind of a line of rash down one part of your body, those lesions themselves are infectious, but it's usually more discreet. And so it's only about 20% chance of giving it to somebody. So the most things we concerned about if we have chickenpox for the first time is that you can have different complications from it. And these complications can be limited to one part of your body. They could be on your skin. And although I say limited to one part, if you get a bacterial infection in your skin, that could easily get into your bloodstream and actually leads to the most common cause of hospitalizations, which is secondary bacterial infections. So bacteria infections that you get after this virus. You can also get pneumonias, or the virus actually goes through nerves and can get into your brain, and it can cause meningitis, encephalitis, and so those are different types of brain inflammation, or ataxia or difficulty walking if it goes to a different part of the brain. If your immune system isn't able to control it, it can go all over the body, which is called dissemination. And then if you get the infection while you're pregnant, it can actually cause severe illness in the fetus or right after they're born. including death. I'm not going to go into any more details. That's it. I'm not going to show you any pictures of this. It's not the focus of this talk, but I wanted to let you know, if you do want to hear a little bit more about personal clinical experience, Transplant Families just put out a podcast. The podcast series is called Growing the Gift. And the episode that came out recently is between two parents of transplant recipients who actually had a personal experience with varicella infection. So if you want to check out that Transplant Families website to hear that podcast, I recommend it. So a little bit about varicella disease in the United States. Guess what? The vaccine worked. So in 1995, the live attenuated vaccine came out. We went from having cases of varicella in the hundreds of thousands every year to under 50,000 with some peaks. And this is only through 2011. So there have continued to be some outbreaks since then, but you can see the dramatic decrease once vaccines were introduced. Unfortunately, I do have to remind everyone that you still do need to get your vaccine, even though the rates of disease are going down. And unfortunately, rates of getting your vaccine are not as high as we would hope. On the left-hand side of this graph, there's an image of the United States, and this shows the vaccine coverage for varicella immunizations by state. And this shows the percentage of kindergartners, so people who entered kindergarten who had both doses, because there's a dose given at 1 year and another one at 4 or 5 years. So by the time they entered kindergarten, they should have had both doses to be considered fully immunized. And unfortunately, our rates are not that high, and they're actually declining. If you look at the school years over the past decade or so, the yellow line is the amount of kids that have had 1 dose, and that's been going down. And then the orange line has the 2 doses, and that is also going down. And remember, this is a vaccine that you start to get when you're very young, because the youngest children are at high risk of complications. So you get your first dose when you're 1. So we won't know how many kids are getting their first dose at 1 right now until they enter kindergarten. So we'll have to keep watching these trends. Now, how is the virus spread? I said it can be very easily spread from person to person, but how does that actually happen? I have a picture of a rose petal with dewdrops, because what we learn in medical school is that the rash of varicella is called dewdrops on a rose petal. And I find it pretty helpful to remember, because it actually does kind of look like that, in that it has a fluid-filled vesicle, so kind of like a bubble, except for it has clear fluid inside of it, and then redness around there. So you might have your normal appearing skin and then a little area of redness, and then in the very middle, what looks like a fluid-filled bubble. And that fluid-filled bubble is full of virus. So you could get the virus from directly coming in contact with that fluid by touching someone or touching their rash, or them touching something and then you touching it. And then you touching your face or your mouth or something to get it into your body. It could also be if that fluid was somehow aerosolized, meaning that it got into the air from the hopping and then it goes out and you then touch it or you breathe it in. Or it's possible that it also can be someone that has the disseminated infection or chickenpox and they breathe it out through their respiratory secretions. So a cough or a sneeze, and then you inhale it. As usual, it's a little tricky that you actually can spread the virus if you're infected before you know that you're infected. So 1 to 2 days before the rash starts to appear, people can be spreading this virus. And it lasts, you can keep spreading it until that last new lesion appears. As I mentioned, you can keep getting new sets of lesions for a while. So you can stay infectious for a while. And you might not know that you've been infected. The incubation period between getting exposed and showing the rash is usually about 2 weeks. So that could mean that this could start taking off and we wouldn't really know until you got to figure out what you were doing 2 weeks ago. So what should you do if you get a letter like this on the right that I just pulled off the internet? It's just a notification of a school that I'm sure a lot of us as parents have gotten, where they say there's some infection in your school. And immediately you just, what do I do with this? Do anything about it? Well, if you have a child who is immunocompromised, you probably want to take some actions right away to know a little bit more. So you could reach out to whoever told you about this exposure and find out some more details. The details you're going to want to know about are, was the exposure indoors, outdoors? Was it in the classroom? Was this the person that your kindergartner shares a table with and they're constantly touching each other? Was it face to face? Are they playing with each other? Are they in football team together? Are they what was going on during this exposure? How long was it? Is it they might have passed each other in the hallway for 30 seconds? Or is it that they're in a class together? Is it longer than 5 minutes or longer than an hour is usually what we want to know. You'll see why soon. And then how long ago was this potential exposure? So how many days ago could this have happened? So once you know those, or even if you can't figure them out, just call your healthcare provider as soon as you can, because we're going to want to use that information to figure out if there's anything we need to do next. And what your healthcare provider will probably do is turn to our handy dandy red book, which is not a fun fashion magazine. It's our guide to all infections for pediatrics. And it has this scary, intimidating looking algorithm that we get to know off the back, like the back of our hands, in infectious diseases, because we go through it not infrequently now with outbreaks. So they're going to first want to know all of that information you've gathered, because this algorithm, I don't expect you to be able to read it, but it starts by asking, were you in close contact? How long was the close contact? And how long ago was that close contact? Then that healthcare provider is going to try to see if you have prior evidence of immunity. Oftentimes that's going to be, have you gotten vaccines when you were able to? Or do you have evidence that you had antibodies developed because maybe you got exposed to chickenpox at some point, you didn't even know it, and so you've actually cleared the virus already, so they can look and see if you have antibodies. And then depending on the answers to all of those questions, they'll consider if they want to use what's called post-exposure prophylaxis, or doing something about it now that you've been exposed. And what that might be, this is a zoomed in portion of that whole algorithm, is if it's within a few days of the exposure and you can receive the live attenuated active vaccines, they might recommend that you get that if you haven't had any immunity before. If you've had the immunity, there's a whole thing that you don't go down this pathway. But if you haven't had immunity prior, then they might just give you the vaccine. But I know that a lot of patients who have had transplants, that might not be a possibility, or maybe you aren't within these 5 days of getting exposed. And those 5 days are important because that's time that the virus is replicating in your body. So we're playing catch up from the moment that you got exposed to trying to catch up to that replicating virus. So ideally within 96 hours, but within 10 days, if you present and you let your healthcare provider know that you've been exposed, you could get a passive immunization, so that antibody, and that's this varicella-zoster immunoglobulin. Immunoglobulins are antibodies. And so ideally it's within 96 hours, but it can be up to 10 days that you can get this passive immunization. And this can help protect you from then later developing disease, from severe complications at least. And this can be done even if you aren't supposed to get the active vaccine. Now, this might take a little bit of legwork. I've done it myself. We were able to get it accomplished within a day. It wasn't that hard, but this is where you'd want to let your healthcare provider know so that they can start making their phone calls. For some reason, they're not able to get it. There is an antiviral option that you can use called acyclovir, but studies have suggested that that might not work at preventing disease quite as well. So as I mentioned, the post-exposure prophylaxis, depending on how long it's been and what your immune status is, and if you can receive active vaccination, might be a type of immunization. Active would be our first choice. Passive is our next choice, and then antiviral drugs. I mentioned on here IVIG, which are pooled antibodies. And I say this because it used to be part of that algorithm before we had the varicella-specific antibodies. there's reasons that it's not on there anymore, although they do work. And so if your child is someone that gets regular IVIG infusions, they might already be getting these passive immunizations. But otherwise, it's not something, since we do have VeraZig, which is the varicella antibodies, that is just an injection, and it doesn't require an IV and an infusion, and you'd be sitting there in an outpatient infusion center or in the hospital with pre-medications and all these headaches. The VeraZig is a lot easier to give because it's just like a regular shot where you can get your immunization and go home. But this is why we want you guys to remember, takeaway from this is call your healthcare provider as soon as you can so that they can help you work through this algorithm with those details if you can remember. So overall, I'm hoping that you guys can remember that active immunization does provide longer and more lasting immunity. It involves both memory immune cells and having your immune cells being able to fight the viruses, but also antibodies. But if you can't have that active immunization, we do have a backup plan for varicella, and that's where we can give you passive immunization with the antibodies. I hope you now have a better understanding of the clinical impact of varicella virus and the many different ways that you can protect yourself and your child from the disease. Please reach out to your healthcare team if you have any specific questions about your child. I'll be around to answer some questions live after this presentation for a few minutes too. Thank you very much.
Yeah, sorry. Hi, everybody. This is we're going to take some live Q&A here with Dr. Heald-Sargent from Lurie, who was the presenter for this session.
So it looks like I see some of the questions that were entered into the chat or the Q&A earlier on. I think I covered a lot of those, but if anybody has specific questions still remaining after the whole talk, I'm happy to go through them. There was one question that I thought I could address, which was about better to get the Shingrix vaccine or to boost varicella immunity or wait for exposure. So I didn't go into the Shingrix vaccine as much. It's not a live vaccine like the one that you would get as a child. So it's a recombinant vaccine, meaning it's just made up of proteins. And right now it's only approved for young adults and older who are immunocompromised. And there's shared decision making with your providers as to whether you're someone that should get it. At our center, we do recommend immunization for most people, but it's something that you should talk about. Don't take my word for it and your individual indications. I will say usually in general, the active vaccines, which Shingrix is one of them, will give you longer lasting immunity and that memory immunity that would also invoke the T cells and the memory B cells. So that would provide somewhat better protection than passive immunity, which is more reactionary and short-lived. Okay, so another question that came up. What type of protocols do I need to follow for my 6.5-year-old? My infant who's going, so we still recommend that everybody get their vaccine. I would, again, the disclaimer, you have to talk to your transplant team. Make sure that your 6.5-year-old who's very far out from transplant is not for some reason on heightened amounts of immunosuppression that would leave them quite vulnerable. If they're not, then typically we want everyone around them to be vaccinated, even with their live attenuated vaccine. So that would indicate that the infant should get vaccinated. Say if there's a possibility that there's a rash or something that could be spreading, trying to keep them apart during that time. But really, it's trying to get that cocoon is usually more beneficial than the risk of transmission. But talk to your specific transplant team because they'll know how much immunosuppression your child is on. And then if your child was vaccinated before transplant, are they still protected? So we can check antibodies after transplant to look to see if they still have those antibodies. I'll say there's some people that just don't make the antibodies that we check for some reason. Usually that's more the case with things like measles, but for varicella, sometimes it happens that you got a vaccine and for not able to check and we're not able to see those antibodies. It could be that your immunity has waned quicker, but it also could be that it's just that you have the T cells that are able to still function. Oftentimes we'll try to boost if we can, if you're in a place that we can. And if not, then you might be eligible to have some post-exposure prophylaxis, or they might do other testing to see how your immune system's doing. Can you please explain why varicella antibodies wane over time? That's in everybody, not just post-transplant. Antibodies, you don't want your body to be clogged full of proteins at all the time from everything that you've been exposed to in your whole life. That would make for very sticky blood. So we want the antibodies that are floating around in your body to naturally go down over time, and really to have those cells be able to respond faster, that those cells have the memory of how to produce those antibodies and how to fight the pathogens, instead of just having like the labels floating around gumming up the works. What should families do if they're not just call their transplant center and see if there's anything else. I think done most of the questions. Happy to answer more. Sorry, keeping up with this. See that there's stuff in the chat too. I think that I've answered almost everything. Let me know if there's any other questions. I'm happy to answer them afterwards, but thank you guys very much, and thanks for joining us today.
Thank you, Dr. Heald-Sargent, for this great information. It's always great to have you on, and you always provide important information that's timely. Well,
Thanks.
bye, everybody.